We will be discussing vasopressors, inotropes, and antiarrhythmic agents and their use in the treatment of shock, congestive heart failure, and arrhythmias secondary to myocardial ischemia and infarction. As a quick review, we know that the cardiovascular system regulates blood flow or cardiac output to various regions of the body, and that this blood flow travels along a pressure gradient of higher to lower pressure. The central nervous system then sends impulses within the vascular system to dilate or constrict vessels, shunting blood to and from these various organ systems. This creates vascular or vasomotor tone and is regulated via the sympathetic nervous system. When this system is affected by various factors, which we will discuss in a minute, it can result in the loss of the autonomic function and result in shock. Shock is defined as a life-threatening emergency reflected in hypoperfusion to organs, leading to decreased oxygen delivery and nutrients to the tissues, causing tissues to die without intervention. There are 6 types of shock, although some combine them into 4 categories. Number 1, cardiogenic or damage to the heart muscle that makes the heart unable to pump adequately, as seen in a myocardial infarction. Number 2, hypovolemic or hemorrhagic shock due to severe bleeding or fluid loss due to trauma, burns, surgery, or dehydration. 3, neurogenic shock, which is injury to the nervous system that impairs impulses to the blood vessels, causing them to remain dilated. 4, septic or distributive shock, which results from an acute infection, usually systemic, that overwhelms the body, such as toxic shock syndrome. 5, anaphylactic shock or hypersensitivity or allergic shock, resulting in histamine release and vessel dilation. And lastly, 6, metabolic shock, which results from acid-base disturbances such as diabetic coma or insulin shock. There is also psychogenic shock resulting from overwhelming emotional responses, but will not be further discussed in this lecture. And of note, sometimes septic, anaphylactic, and neurogenic shock are termed distributive shocks, and some textbooks also list obstructive shock, which is shock due to tension pneumothorax, cardiac tamponade, or pulmonary emboli. In addition to vasomotor tone, vascular volume also affects cardiac output and tissue perfusion. This volume can be measured with a pulmonary artery catheter, and specifically with the measurements of pulmonary capillary wedge pressure, central venous pressure, or preload. The first line of treatment for hypotension and shock are fluids. Medications that can be used for shock are catecholamines, which we learned about in the respiratory medications unit. Norepinephrine or Levophed and epinephrine are examples of catecholamines, and both have the effects of vasoconstriction, thereby raising blood pressure and rate. Norepinephrine is used as an initial therapy for septic shock. Isoproterenol or isoprel has limited value currently. And dopamine is also used in a limited fashion as it has risk of tachyarrhythmias. Phenylephrine may be used in patients that develop tachyarrhythmias while taking norepinephrine infusions, as it induces a reflex bradycardia. The last agents used in shock are vasopressin or pitressin and midorine or proamidine. Vasopressin is a naturally occurring hormone, antidiuretic hormone, and has water retentive effects. It is used as a secondary agent in refractory septic shock and is usually combined with a catecholamine or other vasopressors. Midodrine is used for orthostatic hypotension and to wean patients from intravenous vasopressors. All vasopressors should be watched for leaking of IV fluid into surrounding tissue or extravasation. Patients should be monitored for swelling, blistering, mottling of skin, or pain around the IV site. To minimize the complications of necrosis and gangrene, vasopressors are often given through a central line. Other medications used to treat shock are inotropic drugs such as dobutamine, phosphodiesterase inhibitors such as amiodarone or milorine, and cardiac glycosides such as digoxin or lanoxin. Each of these agents increases myocardial contractility. Dobutamine or Dobutrex is a catecholamine indicated for short-term treatment of heart failure secondary to decreased contractility, but has several adverse cardiac effects including tachycardia, hypotension, and increased myocardial oxygen demand. Milrinone, or Primacor, is more commonly used than enamorone, also called Inacor, since it is less likely to cause thrombocytopenia. Dosage must be adjusted for patients with severe cardiac or renal issues. Digoxin or Lanoxin is used in the management of chronic congestive heart failure, but must be used with caution as it has a narrow therapeutic range and can become toxic in renal insufficiency. Next, let's discuss arrhythmias and their treatments. There are several non-pharmacological treatments for arrhythmias, including ablation, which is applied radiofrequency used to burn a small area of the heart causing atrial fibrillation. It has a 30 to 90% success rate. The second technique is implanting a cardioverter defibrillator or ICD. It is indicated for cardiac arrest secondary to ventricular tachycardia or fibrillation, sustained VT or non-sustained VT with coronary artery disease, MI, or left ventricular dysfunction. It is used if drug therapy will not suffice. Antiarrhythmics can be classified according to mechanism of action according to the von Williams classification system. Class 1 drugs block sodium channels in the atrium. They are broken down into Class 1A, which not only blocks sodium channels, but also blocks repolarizing potassium channels, Class 1B medications, which are used to treat ventricular arrhythmias, and Class 1C that are used in supraventricular arrhythmias. Class 2, used in management of hypertension and post-myocardial infarction, using their antisympathetic properties, and Class 3, used to treat both supraventricular and ventricular arrhythmias by affecting potassium channels. Class 4, also used in SVTs and rate control in atrial fibrillation by working on calcium channels. And Class 5 are miscellaneous agents that work by unknown mechanisms. Our first 1A drug is quinidine or quinagulate, which is used for atrial fibrillation and flutter. It must be used with caution in patients with asthma, muscle weakness, and fever. Procainamide or Pronestal is our next drug used for ventricular tachycardia and torsade de pointe, and disopyramide or Norpace for life-threatening VTAC and paroxysmal supraventricular tachycardia or PSVT. Potassium should be corrected prior to administering Norpace as it is ineffective in patients with hypokalemia and toxic in patients with hyperkalemia. Class 2B drugs include lidocaine or xylocaine and are used to treat ventricular arrhythmias during cardiac surgeries or post-MI. Other examples are mexiletine or Mexitil, again used for life-threatening arrhythmias and also for its anesthetic effects, and toconide or Tonacard, which carries the box warning of pulmonary edema, fibrosing alveolitis, pneumonitis, respiratory arrest, and blood disorders. Class 1C medications are not generally used due to their tendency to increase occurrences of pre-existing arrhythmias. Class 2 medications include our beta blockers, such as propranolol or Inderal, metoprolol, Lopressor, atenolol, Tenorum, Nadolol, Dorgard, and Esmolol or Brevibloc. These agents are used in the management of hypertension and post-MI except for metoprolol, which is used in chronic heart failure. None of these agents should be used in acute heart failure and should be used in caution with asthma, with Esmolol being the safest for this population. Class 3 medications include amiodarone or Cordarone, which is used for ventricular and supraventricular arrhythmias such as AFib, VFib, and VTAC, but may induce pulmonary toxicity as evidenced by local and diffuse infiltrates and cough, and interacts with many prescription medications, herbals, and over-the-counter medications, often with severe or life-threatening results. Other examples are Trondarone or Molotek, which is similar to amiodarone but with reduced toxicity to the thyroid gland. Dofetilide or Ticosin for the maintenance of normal sinus rhythm after cardioversion, but carries a risk of torsade de pointe, particularly in women and those with congenital heart disease or impaired renal function. Sotalol or Betapace for ventricular or supraventricular arrhythmias, but requires inpatient EKG monitoring. And lastly in this class ibutylide or Carvert, which may be used as an alternative to electrical cardioversion for recent onset atrial fibrillation or flutter. It cannot be mixed with any class 1 or 3 medications for at least 4 hours due to the combination causing long refractory periods in the heart. Patients should also receive anticoagulants due to the potential of formation of blood clots. Class 4 medications or calcium channel blockers, CCBs, include verapamil or isopten and diltiazem or cardizem. Both manage supraventricular and ventricular arrhythmias by not only blocking calcium channels, but by slowing AV node conduction as well, and are good alternatives to beta blockers for those with respiratory disease. Lastly are the class 5 or miscellaneous antiarrhythmics. Digoxin and lanoxin falls into this category and was previously discussed. And again, adenosine or Dinacart falls into this category as well. To finish up this chapter, we will briefly discuss other routes of administration of medications that may be used if IV access is impossible, such as with elderly patients, infants and children, and IV drug abusers. For this population, we may need interosseous access. And as a reminder, the drugs that can be administered via the endotracheal route are naloxone to reverse opioid overdose, atropine used in profound symptomatic bradycardia, vasopressor for refractory septic shock, epinephrine and asystole in ventricular tachycardia, and the class 2B drug to treat ventricular arrhythmias, lidocaine. Just remember the acronym NAVEL or NAVEL.